All right. So we're going to talk a little bit about surgical and non-surgical airways. So quick anatomy review here. I know we have the thyroid cartilage, and below the thyroid cartilage, we have the cricoid cartilage. In between the thyroid cartilage and the cricoid cartilage, we have the cricothyroid membrane, which is going to be the place for a cricothyrotomy. Um, you also notice that we have the carotid arteries and the sternocleidomastoid mastoid muscles running through there. So when palpating the anterior midline of the neck, we have to be familiar with several key landmarks in order to do cricothyrotomy. The most obvious prominence is the upper aspect of the thyroid cartilage, or as we call in layman's terms, the Adam's apple, which is easier to palpate than men and women. But yes, women do too have a Adam's apple. Just below the thyroid cartilage is the cricoid cartilage, a less prominent feature which is somewhat more difficult to palpate, especially in larger patients. The vocal cords lie approximately 1 centimeter above the cricoid cartilage. It's important to remember. So just 1 centimeter above there is the vocal cords. The thyroid and cricoid cartilage form the larynx, or the voice box, which is where we talk and where sound is produced. Below the larynx, several additional firm prominences are palpable in the anterior midline of the neck. The cartilage rings of the trachea are there, and we can palpate those. Down below, we also have the carina, which is the location where the trachea will bifurcate to the left and right mainstem. And bilateral to the inferior larynx and upper trachea lies the thyroid gland, which, unless enlarged, is usually not palpable. Okay, the thyroid gland itself. So between the thyroid cartilage and cricoid cartilage is the cricothyroid membrane, which is a thin sheet of connective tissue or fascia that joins the thyroid and the cricoid cartilages. The cricothyroid membrane, the only covering of it is skin itself. So that's why it's a rapid access point and an ideal access point for aggressive airway management in patients we don't have other alternatives to. We will encounter a few important blood vessels in the immediate region of the cricothyroid membrane, but they can be avoided. The superior cricothyroid vessels run at a transverse angle, meaning diagonally, across the upper third of the cricoid membrane. If a cricothyrotomy is performed across the lower third of the membrane, these vessels should not be encountered. So we should be able to avoid that. The higher we get with the procedure, the more encounter with bleeding we're going to get. The lower we go with the procedure, as long as we're still in the cricothyroid region, the less problem we should have with bleeding. So the EJ run vertically and are located lateral to the cricothyroid membrane. If the membrane is incised vertically when performing a cricothyrotomy, the jugular veins will be avoided. It's very, very rare. Actually, it should never happen that you should actually hit the jugular veins during a cricothyrotomy procedure. If you actually do, you've probably done something wrong, and you're going to have bigger fish to fry other than airway management in this case. So when performing a cricothyrotomy, you should expect to encounter minor bleeding from the subcutaneous and small skin vessels as you incise the cricothyroid membrane. This bleeding is very easy to control most of the time, though. Just some simple 4x4s, you should be able to control the bleeding, and you should be able to make the bleeding stop after you get the tube inserted with just some direct pressure from that gauze. You should be able to get all bleeding under control. So it is a surgical procedure, but it's an emergent surgical procedure, which will involve incising the cricothyroid membrane with a scalpel and inserting an endotracheal tracheostomy tube directly into the supraglottic area of the trachea. So it's important to remember, like I said, that it is an emergency procedure, but it is still surgical. It is invasive. So there are obviously going to be some risks with the procedure itself. There are several advantages to a cricothyrotomy. There are disadvantages as well. The main advantage is being that it can be performed quickly. It's technically easier than performing a tracheostomy, and we don't have to manipulate the C-spine when we do the procedure. I mean, come on, we've all probably seen an episode of Rescue 911 or some other action movie, and all you need is a big pin and a steak knife, and you can get this done. Granted, that's not really the recommended method to do this. We're going to use all our proper equipment, but again, it can be done very quickly and very easily. There are disadvantages. You can't really do the procedure in children, or patients that have short, muscular, or fat necks make it very, very difficult to do the procedure on. Because you've got some false tissue, you got extra tissue in there that's going to get in the way, and it's going to be very difficult to palpate and locate your landmarks. So why do we do a cricothyrotomy? Well, if we are unable to secure a patent airway with our more conventional means, meaning we cannot intubate the patient, we cannot get a nasal intubation, we can't orally intubate, we can't digitally intubate, our other rescue airways aren't working, like a combi tube, a king airway, or an LMA, that is what's going to be the indication to do this. Not just because you can is not the reason to do it. Most of you will probably spend your entire career and never do a cricothyrotomy. Some of you may do a 1 or 2. All right? Some of you may do more than that. But realistically, should be few and far between in the times that you do a cricothyrotomy, because you have plenty of other airway devices that you can utilize. But again, it is a backup mechanism for us if we have to secure an airway. Situations that preclude you from securing your airway by other means include maxillofacial trauma, complete upper airway obstruction, if you got somebody that's having a true anaphylactic reaction, somebody that's got trismus and we can't facilitate a nasal intubation. All of those are going to be indications that are going to guide you in the direction that maybe you need to go ahead and cric. So patients that have the severe maxillofacial trauma can present challenges, even to experienced paramedics with lots of airway experiences. Some of the patients will have mandibular fractures. And some of them you're not going to be able to get a seal with the BVM. You're definitely not going to be able to find the landmarks for intubation. You just have no other method of controlling that airway or getting the tube. Posterior lacerations to the tongue with severe oropharyngeal bleeding. Visualization of the upper airway anatomy would be extremely difficult without performing frequent airway suctioning. So in order to prevent that aspiration, we go ahead and elect to do a cricothyrotomy. Patients that have complete upper airway obstruction. If we cannot ventilate them with a BVM, we can't get a traditional endotracheal intubation, that's going to be the time that maybe you need to go ahead and consider doing a cricothyrotomy. Patients who have trismus, if you cannot open the airway by any other means, you don't have the ability to do an RSI. Because obviously if you paralyze the patients, you're going to release the trismus, but if you can't do that, then you're going to go ahead and consider doing an RSI procedure. The only contraindication really to doing cricothyrotomy is being able to secure the airway by another means. If you can get an airway by some other method, that's your contraindication for doing cricothyrotomy. So again, cricothyrotomy should be your very last ditch effort in your steps of airway management to control that patient's airway. Other contraindications that are relative contraindications is the inability to identify the anatomical landmarks if you can't find where to go. Patients that have crushed injuries to the larynx and the trachea. Underlying anatomic abnormalities, like let's say somebody's got a goiter being an enlarged thyroid gland due to iodine deficiency. They've got a huge goiter in there, then obviously that's going to interfere with your landmarks and going to make it difficult. And all children under the age of 8, we are not going to do a cricothyrotomy on. So there are complications associated with doing a cricothyrotomy. Severe hemorrhage is usually secondary to inadvertent laceration of the major vessels, which does occasionally occur. Sometimes you cannot avoid it, but most of the time, like I said, if you specifically do the procedure properly, bleeding should be minimal. You should be able to control the bleeding simply with some gauze and some direct pressure. Taking too long to do the procedure is going to produce hypoxia. So obviously we want to do this procedure quickly. While it is a surgical procedure, it is an emergency procedure. So we want to do it as quickly as possible, but we also want to do it as aseptically as possible. Tube misplacement can happen. Can cause subcutaneous emphysema. You wouldn't think about this being common. Realize that when you go to trace that tube through the hole made to the cricothyroid cartilage, sometimes you actually don't get into the trachea. You actually start placing the tube into the soft tissue of the neck. So your tube would be laying right here on the folds of the neck. You start to ventilate, it's going to create that subcutaneous emphysema, or that air that's going to be under the skin. If you don't know what subcutaneous emphysema is like, or if you've never felt it, it's like, just imagine somebody has the bubble wrap that comes in packing material underneath their skin. All right, that's going to be subcutaneous emphysema. And there's always a risk for infection to the patient. Realize it's going to be a complication that we're going to see down the road. Something that's going to be an emergent issue that we're going to see right off the go. So equipment, well, ultimately you can buy a commercially manufactured cricothyrotomy kit, which is the easiest way to do it. Everything's there. You open it up. All the stuff's there. You've got your tools. You got your scalpel. You got your cleaning agents. You got your markers. You got everything that you need right in the kit. However, you can make your own cricothyrotomy. The equipment that you need to have is here in red. You need a scalpel, an endotracheal or tracheostomy tube. Typically, we're going to use a 6.0 ET tube. Is going to be the most common size tube that we're going to utilize. You want some type of commercial device to secure the tube. They do make commercial devices for cricothyrotomy, or you can go ahead and use some tape and gauze, and some bandaging material. You want curved hemostats, or you want a tracheal hook, or both. Or you can make your own tracheal hook, which I'll teach you in lab, which is basically you use a stylet and make a hook at the end of it, or you can take a 16-18 gauge needle, put it at the end of a syringe, and bend your needle over, and you've got a little tracheal hook to pull that opening and make sure everything stays open. You definitely want to have a suction apparatus, something to do the suctioning, because there is going to be possibly some bleeding that's going to ensue. As well as you want to make sure that the oropharynx stays clear as best you can. And you want your gauze pads for bleeding control and your BVM. Again, this is going to be a rapid procedure. You want to do it as quick as possible, but you want to be cautious. Follow proper BSI. Identify your landmarks and clean your landmarks. Again, you want to make sure that you find the proper landmarks, which is going to be the thyroid cartilage and the cricothyroid cartilage, and in between there, or cricoid cartilage, and in between there's going to be your cricothyroid membrane. Keep your aseptic technique. Cleanse the area with iodine, or most places are going to now chlorhexidine. You can use a chlorhexidine, which works better unless patients have allergies to it. But again, you want to clean the area very good. Avoid touching the area once you clean it, because again, that defeats the purpose. All right, and don't blow on it to make it dry faster, because then you're blowing all your cooties all over the potential incision site. So again, keep it as clean as possible. While you're locating and preparing the site, your partner should be preparing your equipment, making sure the cardiac monitor's on, all monitoring equipment is set up and ready to go. While you stabilize the larynx with one hand, you want to make a 1 to 2 centimeter vertical incision over the cricoid thyroid membrane. Vertical meaning what?
Superior to inferior.
Superior to inferior, up and down. Okay. Once the incision has been made, you're going to insert your hemostat or your tracheal hook into the opening and spread it apart. All right. And your partner should be there with some gauze and control any bleeding that may occur, and to make sure that you can still see what you're doing. Once you get the trachea exposed, you're gently going to insert your 6.0 cuffed endotracheal tube or 6.0 Shiley into the trachea. Once you get it in place, you're going to inflate your cuff with 10 cc of air. Attach your BVM and auscultate. You want to go ahead and still auscultate for epigastric sounds, just like with intubation. Make sure that there aren't any, and then go ahead and verify that you have lung sounds in your other 4 spots, and also listen above the sternal notch. Then you're still going to use your additional confirmation devices, such as Untitled CO2, pulse oximetry, missing of the tube, all of those good things. After you've confirmed that you've actually placed the tube in the proper location, you're going to go ahead and secure with either the commercial device or tape. All right, and go ahead and control your bleeding as best you can. But again, typically with just some simple direct pressure, you're not going to have any issues with bleeding control. So real quickly to going over the steps of an open cricothyrotomy. Take body substance isolation. Get your gloves and a face shield should be used. Safety glasses. Check a symbol and prepare your equipment. Put the patient's head in a neutral position and palpate your landmark and cleanse with an appropriate solution. So there you can see the palpation there in step 3 and step 4 on slide 30.
Step 2, once again.
He's checking his equipment.
Looks like he's cutting his tube.
And you may need to cut your tube, especially if you don't have a commercially made device. You need to go ahead and cut your tube off because you don't have to, but you don't need that long of a tube. You just need enough to get in and cut it. To be honest with you, I typically cut mine after I'm already in. I'll cut it down to size because again, you don't need all that end dangling off the top of it.
Oh, and then you can pull it and make her off.
Yeah. So
yeah, that's my question was, how could you hook your bag up to the cut piece of tubing?
I got you. Yeah, no, your adapter will slide out and slide back in. Okay. So then you're going to stabilize the larynx, make your vertical incision over the cricothyroid membrane, and then you're going to puncture the cricothyroid membrane and make a horizontal cut 1 centimeter in each direction. Spread the incision apart with your trach hook or your hemostats and insert the tube into the trachea. As 32 demonstrates, step 5 shows the vertical incision. Step 6 shows the horizontal puncture. Step 7 shows the hemostats being utilized to open it up. And step 8 shows the actual placement of the tube into the trachea. You're going to inflate the distal cuff, attach the Untitled CO2 detector in between the tube, and ventilate your patient to confirm proper placement by auscultating the apices and the bases, and then secure the tube with a commercial device or tape. So now go to the next slide, you can see the actual diagrams of this. Again, it would be great if we could actually practice this on cadavers. Maybe one day that will happen. Right now, the mannequins work for us. But as you can see in step 12, the important thing is we do have some gauze there to make sure to absorb any bleeding that may be going on. So any questions on an open cricothyrotomy? Okay.
Yes. Let's say the patient has a pneumo. We have a, what do you call it? When mediastinal, tracheal deviation.
Okay.
Would that pull the jugular over a little bit?
Possibly, but you should probably do a decompression before you do the cricothyrotomy.
Okay.
So if you do a pleural decompression, put your and alleviate that tension pneumo, you should get everything back in line again. And also just remember too, on a tension pneumothorax, just as a side note, once you have somebody that actually has tracheal deviation, you're probably not going to need to cric them anyway because they're already DRT. So DRT meaning dead right there. It's already over. So you might as well go ahead and call the funeral home an OMI. So needle cricothyrotomy. We don't do needle crics in New Mexico. However, you are expected to know needle crics. Because again, this is an important skill. But a needle cricothyrotomy uses the cricothyroid membrane as an entry for the airway. However, instead of incising the cricothyroid membrane and inserting a tube, you're going to use a 14 or a 16 gauge angiocath, insert through the membrane and into the trachea. So the way we get this is by using high pressure jet ventilation to the hub of the catheter to get it in. All right. So you're going to have some special tools and techniques in order to be able to do a needle cricothyrotomy. It is a temporary procedure until a definitive airway can be obtained. Many states do not allow for an open cricothyrotomy. They only allow medics to do a needle cric. However, in New Mexico, we do open crics and not needle crics. Okay, because ultimately an open cric is going to be a much better airway than a needle cricothyrotomy. You think about all the air that you're getting is the air coming through a 14 gauge catheter, even through jet insufflation. You think you're getting much air? No. you're not. But it's better than nothing. It's better than no air at all. It's faster and easier to perform than an open cricothyrotomy. Fewer complications, lower risk of causing damage. And again, we're not using a scalpel to perform the procedure. We're just simply inserting a needle. The other advantage to doing a needle cric, which we will play with in lab, is it allows for retrograde intubation. Because again, we can trace that wire up through and pass the tube down. It is a small bore catheter, and it allows for an easier passage. Needle cricothyrotomies, there are some disadvantages. Again, using that small bore tube to ventilate the patient does not provide protection from aspiration as an endotracheal or a tracheostomy tube would. Because realize that again, when you're doing this, you can't inflate a cuff on a 14 gauge catheter or a 16 gauge catheter. It's there, so the patient's still going to be able to aspirate potentially if they vomit or any secretions that they have in their airway. A large bore tube would clearly fill the diameter of the trachea, protecting from esophageal regurgitation. And another disadvantage to doing a needle cricothyrotomy is that you got to have the jet insufflation device. If you don't have a jet ventilator, you're not going to be able to deliver an adequate tidal volume to the patient. So your indications, it's going to be the inability to ventilate the patient by other less invasive techniques, severe maxillofacial trauma just like before, inability to open the patient's mouth, and uncontrolled oropharyngeal bleeding. If the patient has a complete airway obstruction above the site of the catheter insertion, needle cricothyrotomy should not be performed. And if you don't have the equipment available to you, you definitely should not do a needle cricothyrotomy. What's the biggest piece of that equipment going to be? The jet ventilation device. If you don't have a jet ventilation device, you can't do it. The other complication to this is improper catheter placement can result in bleeding to the adjacent structures. Even if the catheter is correctly placed, excessive air leaking around the insertion site can cause some subacute emphysema to ensue. So again, there are lots of complications with doing a needle cric, just like with a surgical cric. When you're using a jet ventilator, it's important to remember that the release valve should only be open long enough for adequate chest rise, because otherwise you're going to potentially cause barotrauma. So we don't want to cause a pneumothorax, because again, it's called a jet ventilation device for a reason. It's jet forced air is basically what it is going into the lungs. So what do you have to do a needle cric? Well, you need to have a large bore IV catheter, 14 to 16 gauge, 10 cc syringe, 3 mLs of water or saline, 50 psi oxygen source, and a high pressure jet ventilation device and oxygen tubing. So follow your proper BSI precautions, prepare your equipment, get 3 milliliters of sterile saline into a 10 ml syringe and attach the syringe to the IV catheter. Place the patient's head in a neutral position, locate the cricothyroid membrane. Go ahead and cleanse the area with an iodine-containing solution, or, like I said before, chlorhexidine works out much better because you don't have less allergies. Stabilize the patient's larynx. Insert a needle into the middle of the cricothyroid membrane at a 45-degree angle towards their feet. Okay. You'll feel a pop as the needle passes through the cricothyroid membrane. Once you feel the pop, insert the needle approximately another centimeter further, and then aspirate with the syringe until we get air back. We should be able to aspirate air easily and see saline or water bubbling into the syringe if we are in the trachea, because we've got air. If we're not in the trachea, obviously we're not going to be pulling air. We'll be pulling vacuum. If we get blood or we meet resistance, we need to reevaluate the placement, because odds are we're probably in the wrong spot. We're somewhere other than inside the trachea. After we confirm correct placement of the catheter, we're going to advance the catheter over the needle until the catheter hub is flush with the skin. We'll draw the needle and place it in a sharps container. Then go ahead and open one end of the oxygen tubing catheter and the other end of the jet ventilator device. So one end goes on the catheter, one goes on the jet ventilation device. So then we're going to ventilate by opening the release valve on the jet ventilator and getting chest rise, or as close to chest rise as we possibly can. Listen for breath sounds and epigastric sounds. See if we hear any. In order to prevent overexpansion in the lungs, make sure that we turn the release valve off as soon as we see chest rise, so that we don't cause a pneumothorax or an mediastinum or any other complication. Exhalation will occur passively, so we don't have to worry about that as we put the air in. The exhalation is still going to just happen for us. We should ventilate the patient at a rate of 20 times per minute. That's a little fast, isn't it? But why are we going to ventilate if we're within this case at 20 times per minute?
They're not getting much oxygen. They're not getting much air.
Yeah, we're not getting the volumes that we normally get, so we've got to give them. We've got to increase their rate since we're not getting the volume. So we're going to secure the catheter in place by folding up a 4x4 gauze pad under the catheter and secure it in place with tape. So quickly again as a review, take BSI precautions. 14-16 gauge IV catheter, 10 ml syringe with 3 ml of saline, and put the patient head in a neutral position and palpate your landmarks, as you can see being done here. Cleanse the area with iodine, stabilize the larynx, and insert the needle towards the feet, and aspirate the syringe to determine correct placement, which you can see step 4 there, cleansing and palpating. Step 5, the angle going in with the syringe. And again, at step 6, you can see aspiration taking place. And again, you can for that bubbling. Once we know that we're in the right place, we're going to slide the catheter off until the hub is flush with the skin. Place the syringe needle in a puncture-proof container and connect our tubing, one to the insufflation device and one into the to the edge of the end of the catheter. You can see in step 9. Again, that's what we're going to do. So then we're going to open the release valve on the jet ventilation device, auscultate our lung sounds, and secure with a 4x4, which we in step 10, 11, and 12 there. You can see how the jet insufflation device actually works and is utilized. So the only other thing we're going to talk about, which we will practice in the lab, is just retrograde intubation, which is done similar to a needle cricothyrotomy. Again, instead of inserting that catheter towards the feet, we're going to insert the catheter towards the head or caudally. And then once we get it in place, then we're going to trace that guide wire up through the catheter, out, and then trace our tube down until we get it into the trachea. All right. So that is surgical airways. Realize that you have other steps to utilize before we get to a surgical airway. As a paramedic, our gold standard of airway security is a
Endotracheal.
If we can't get an endotracheal tube, what do we use? We use if we can't get a nasal tracheal tube, then we move to our rescue devices. And our rescue airway devices are a combi tube, an LMA, or a King, or anything in those lines. If we cannot utilize one of those rescue airway devices, that is when we go to cric. Realize we do not go straight to cric if we can't get a tube by normal intubation. Cricothyrotomy is an emergency last-ditch effort. Hope everybody has a good evening tonight. Thanks for watching.